need to talk about. So there's a few things that I want to make sure that everyone understands. There is in the literature the suggestion that if you do not feel well on thyroxine, that you should have a trial of therapy. That's what it says, okay, in the guidelines of liothyronine and other things, okay? And the problem is that is subject to a very large placebo effect. And so I think that guideline needs to be removed, okay? And I've got evidence, I think, that might convince some people, but not all. The other thing is there's no objective benefit of liothyronine in any blind trial. And the third thing is this statement you will hear from patients that I have heard a lot from, because of course, these are the patients who are on T3 and they say, well, I've got this gene. You think, what gene is this? And that's the one, RS225014. It's a SNP, okay? It's a single nucleotide polymorphism, and it codes for a mutation from threonine to alanine in the deodorinase gene. And really the question is there good evidence or any evidence for the variants? And I'll show you why the evidence that's put forward by various societies may be suspect. And the other thing is tired and depressed patients are vulnerable, and they're manipulated by websites especially, but sometimes private doctors, to take various things, and also nutrition. There are a group of nutritional type doctors who practice, and they're not really doctors at all. So here is the Bds consensus so far, and this is with the US, Europe, and UK, that there is actually no evidence that anything other than thyroxine is of benefit. And so the basic guideline is that adding T3 has no benefit, and if you become thyrotoxic, which many people do, and suppress the TSH, this puts you at risk of AF and osteoporosis. Okay, that's a theoretical risk. We know it happens. And then some people believe that their complete exhaustion, and I've seen quite a few of these people, they are absolutely bed bound, cannot get out of bed until they have their T3 tablet, and then like magic, they spring out of bed. Okay, so it's a very, very effective treatment for some people, or so they say. So there's a huge variance in activity, right? This exhaustion with a very high exhaustion score, I'll show you those in a minute, disappears completely when you have some T3, if you're one of these people with the so-called gene. So this is my first problem of the statement trial of therapy. And quite a lot of eminent thyroid people say, we've got to keep an open mind, got to keep trial of therapy. And the problem is that you only, so this is well-being on the y-axis, and all of us have good weeks and bad weeks, and good days and bad days. And what happens is when you are well, you don't look for help. And when you are at your utmost minimum down here, you go and see someone private. I can't bear it. I'm so knackered. Okay. So they start some treatment of whatever it is. Okay. It might be liothyronine, but whatever they take, they will get better because they're at their utmost minimum when they start the treatment. So if you give them nothing, they would get better too, or a placebo. Okay. But then after a period, it wears off, okay, like all these things. So they go back to their private doctor and he says, double the dose. And sure enough, it works, okay? So this is a thing that I think happens quite a lot. And so they're on it, okay? And so our CCG commissioned a T3 withdrawal clinic in 2017. So we've been for 5 years. Most patients are on thyroxine and a bit of T3. It's quite variable. Some are on 2.5 micrograms once a day. Others are on 10 3 times a day. It's quite a big dose. I've got one patient on 20 QDS, which is an enormous dose. It's very toxic. They're also often on a number of other placebos, I'm going to call them. Okay, if you look up ashwagandha, you'll find that it's good for everything. Okay, as is turmeric, as is coenzyme Q, that you can actually get, believe it or not, in Holland and Barrett and Boots. Okay, coenzyme Q sounds very scientific. It's in all the mitochondria that patients will tell you. It's very good for you. But of course, if you swallow an enzyme, it'll be destroyed completely in the gut. So it's slightly pointless having coenzyme Q if it's real. I don't know how you know it's real. And then they're on vitamin D. And the problem is when they come to the clinic, they're on all this stuff and the T3, and they're still tired. And they say, I can't possibly stop. I'll be so tired if I stop any of these treatments that I won't. And what happens is, when they come to see you, they're really tired. Okay, so if they're tired, then they won't stop the drug. Okay, so what happens is they wait till they feel a bit better. And they go, all right, then I feel okay now, I'll stop the treatment. And sure enough, that's immediately linked to withdrawal tiredness. And that's because if you withdraw here, that will be all right. They never do that. They wait till they're well because they're petrified to stop the drug if they're tired. Okay. So that is the added problem. They can't stop it because when they do stop it, they associate it with worsening symptoms. So let's move now to some objective markers of well-being. So this is the GHQ-12, and there are 12 questions, and in italics are negative questions, and in normal font is positive questions. And so you're asked these 12 questions, and you can score between 0 and 3 for each question. So if you can concentrate better than usual, you get 0. Okay, so 0 is a really happy person. If it's in italics, the score, this is inverted, okay? So lost much sleep. If you lose less sleep than usual, okay, then it'll be 0 because it's in italics. But basically, if you are a very happy, active, confident, reasonable person, you will score 0. And if you are very depressed, you can't concentrate, and you're really tired, you get a score of 36, okay? So if you can't concentrate, much less than usual, you get 3 for each question. So your score is from 0 to 36, okay? Quite a wide range. So here is a paper published in 2002. Now, this was simply comparing people on thyroxine with normal matched controls. So it took about 500 patients, 597 patients on thyroxine, and they put them through the questionnaire of tiredness. And on the x-axis, you can see their score, okay? So most people score about 12, okay? A point, basically about 1 for each question. If you look at the range, you'll see that the average of the white bars is 11.39. Okay, that's the controls. And the average of the black bars is 12. So not a huge difference, right? But it's significant. So this paper suggests that being on thyroxine means you're a tired person right from the start. Now, the difference is tiny, but it's significant because the N is big enough. And they've pointed out that the white bars are more prevalent in the lower scores, the less tired people, and the black bars are higher on the right-hand side, okay? So it's skewed to the right. So being on thyroxine does link to tiredness, but there's a couple of things that don't fit. So for example, the very not tired people, there's actually more on thyroxine than controls. And in this particular really tired people, there are more controls than on thyroxine. So there are exceptions to this. And so I don't know whether you can really say that this is a significant finding. It's not clinically significant. The difference is so small, I think. Okay, but just give you a feel for the range, right? 0 to 36 with a peak at between 5 and 12. Okay, just remember that in terms of, because it comes back with a T3 patients. So then the question is, how does the thyroid control each organ? Well, what happens is the thyroid gland makes mostly T4, which goes to all the target organs, and each organ has got deiodinases. And they basically deordinate the amount that you need locally, okay? And the question really is, there is some T3 in the circulation, and what does it do? Okay, maybe there's a background level, but it is there. And when you give people thyroxine, it's there too, okay? So it is present. So here's the first really good study, okay? This is in Cardiff, Colin Dyan's team. They took 573 people on thyroxine. They reduced the dose by 50 micrograms. So they said, if you're on 200, take 150 plus this capsule. The capsule contained either thyroxine 50 or T3 10. It was blind and randomized, really well done study, and they did the GHQ-12 scores, okay? And basically, here they are. So here's your tiredness score of 13.5 on average. You go on to either T3 or placebo, okay, a bit of T4 as it were, and you'll notice that everyone gets better. That's a fantastic placebo effect that persists for a year. So just being in a study makes you less tired, whichever group you're on, okay? So really persistent placebo effect, very good publication, okay? And it was concluded, therefore, there's no good evidence of any better than T3, and they point out there's a large and sustained placebo effect. So why do you want to use it? Because at this time, this is when T3 was actually relatively cheap. It was £4 a month, but T4 was £1 a month. So you might as well go for the quarter of the price of the NHS compared to T3. And that was that paper in 2005. And then there's a meta-analysis the next year, looking at all the studies around the world, and they came to the same conclusion. T4 monotherapy should remain the treatment of choice, okay? Because when you look at all the studies that, when they're blind, randomized, there's no benefit. Then what happened was the price of T3 started to go up, okay? And this is from the CMA website, Competitions Market Authority, and they basically have noticed illegal practices that they've got evidence for now between these two periods. So there's going to be a large fine soon, but basically that's what this company did. Thyroxine still remained at about £1.50. So the difference in price became absolutely enormous. And as a consequence, in January 2020, NHS England put forward this statement: primary care physicians should not initiate T3 for adults or anybody, okay? And consultants could give it in rare situations if there are some national criteria. And they say there's no evidence of benefit. And they also say that we should not take on prescribed T3 where the treatment is recommended by a consultant endocrinologist after a trial has been carried. This trial is the problem, right? GPs should not take on prescribing patients given T3 in private clinics abroad or via other self-funded routes, okay? So they've spotted the problem. So then this is when trouble started. This is a really interesting paper. This is a group of very eminent geneticists who took the study I just showed you. They reanalyzed, that was 2005, the first publication, this is 4 years later. They took the samples and sequenced a number of genes, okay? So these are the deodorinase, now they're not the gene, these are SNPs, okay? These are single point mutations. So we don't even know if they're significant, but I'll give you an example. So what they've done is, for example, for this point mutation, okay, there's thymidine and cytosine, and obviously you have two copies. So if you're a TT person, which is most people in this group, okay, your tiredness score is 13.4. If heterozygote, your tiredness score is 13.5. And if you're a CC, one of the small groups, it's 11.7. So it just happened they were a bit less tired in that group, but that was not significant. Then you do it for 20 different SNPs and you start to find a significance. Now, what they've done, I think, is not correct here. They looked for a trend. They said, look, if you're a common homozygote, then you're not very tired at 12.8. You're heterozygote, you're a little bit more tired, and you're really tired at 14.1, not a huge amount, if you're one of the 87 people with this SNP, CC, okay? And these two are linked together. There is, as it happens, a significance for trends. Now, I don't think that's a valid statistical thing, but that's what they've done. So 13.4, 13.5, 11.94, most of them are the same, but this one goes 12, 13, 14 as a rise, okay? And they say there's a gradient there. So if you look at this group, here is the placebo effect I've told you about. They've basically taken these two groups and broken them down by that gene, okay? Not that gene, they call it the gene, but it's by a point mutation. Okay, so 12, 13, and 14. So what they've done is, if you split the data up between people who are TT, TC, and CC, okay, and look at the same graph, hang on, this graph, but split into 3 bits, because there's 3 different populations of that gene, then you see this, okay? So when you're TT, you're tired, you start taking either the drug or placebo and you get less tired and you remain less tired. And the same for TC. And they say, look, this group of people, they all got a bit less tired, but look how tired they were. They're nearly 14.5 and they went down to 9.5. So this fall in tiredness is highly significant compared to thyroxine. So this proves that this gene makes you unable to convert T4 to T3, and therefore the tiredness improvement is much less with T4. Now, this difference is 2 points on that 0 to 36 scale, okay? But because of the N, it's significant. So they say there's a trend there of tiredness getting worse and worse and worse, okay? But the key thing is that we're talking about this is the points publication, that when you take T3, you're a bit less tired. So their conclusion then is, our results require replication, they sure do, okay? But suggest, and this is the problem, that commonly inherited variation in the DI2 gene is associated both impaired baseline physiology on T4 and enhanced response to treatment. And it did not affect blood levels. So the conclusion is blood tests are useless. You need to actually look for the gene. Now this mutation codes for this mutation, threonine alanine 92 substitution. So this is a very tricky game because I think we've got a duty to protect these people because they're being very ripped off. First of all, by having expensive placebo like T3, and secondly, by doing gene tests that have no consequence. But they'll tell you, I've got the gene. I've been told I've got the gene. Sometimes it turns out when you get the results, they've got the normal gene. So they don't even understand it, but they just do the blood test and then they tell everyone they've got the gene. And so doctors get a bit worried and think, I better prescribe some T3. So it's quite addictive, as I pointed out. So this is a withdrawal protocol, and I've put there's another variant of T3 combined with T4 called ERFA. Okay, this basically comes from porcine thyroid glands, and it comes as grains, and a grain is 30 micrograms, it turns out. So what I've done is I've taken this from the steroid withdrawal pathway that patients told us about, and I'm trying it out, and it actually does work because it basically you very, very slowly reduce the dose of T3 you're on over 14 weeks, depending on whatever T3 you're on. You substitute 60 for what they're on. And you monitor their blood tests. And basically, if they do it slowly, the T3 doesn't fall because they start to make more of their own T3 as time goes on. They need placebo sometimes, but if they understand this, then they slowly come off it. So this is the most recent important publication, and this was published in June last year, and it's comparative effectiveness of T4 desiccated thyroid extract, so in other words, ARMA, that's from porcine, and then tablets containing T4 and T3. And it was a very nicely done study. And these are slides that, in fact, Mohsin did, and he spoke about this paper in the Journal Club last year, I think, when it was out. And it's a double-blind proper crossover. So all of the patients went through all the pathways, so 90 of them. They had T4 alone, a combination of T4 and T3, and then desiccated thyroid extract, all the other way around. So all of them went through all these choices. And at the end, there were 75 of them. And as we've seen, all of the quality of life questionnaires, there's no difference. And they did more than just the GHQ-12 and SF-36. Lots of questionnaires, but basically, there's no difference in tiredness, whichever one they take, okay? And obviously, when you take T3, there are some differences in levels of T3 compared to T4. So that is significant. The blood tests definitely show that you're on T3, but the tiredness scores don't change. So that concludes that T3 in a blind study is of no benefit, okay? But then what they did was they sub-analyzed the people who felt tired, because what they said is, okay, there's a subgroup of us who've got this gene that makes us unable to process T4 to T3. So we need to find those really tired people and reanalyze them. So they did that. Now, if you take people who are tired on T4, then by that thing I showed, that graph, they will get better when you switch to something else. Those who are at the bottom end when they are on T4. So this is a graph showing the difference in their tiredness score. So in red, I put what the tiredness score is. So they said, let's call it low, medium, and high tiredness, okay? So this high group are very tired when they start. And of course, it drops because as you tend towards the mean, because you're starting off high, it will drop. And so their scores improved when they switched. And so they say, well, that is interesting, but all it shows is that when you switch from being very tired to anything, that you feel less tired. And what really was good about this paper was they then looked at that same gene, okay? That same gene, yeah, okay, so just to point out, if you are very tired, then you want to switch, okay? So these two were happy with T4, okay? So tired on T4, they preferred something else. But those people who are not tired, because the L, low tiredness, they stayed on T4, okay? They asked them which one they preferred. But this is the interesting thing. They looked at the same gene across the three tiredness groups and didn't find it present. Now, they did have to conclude that the numbers are very small, but this would have been evidence that the gene did something in the brain. And they found that even not tired people have the same prevalence of this gene that very tired people did have. Okay, so we haven't had this gene replicated, and every other study that's looked at it has not found that this gene is linked. Then you start doing really bad studies, and this is Frontiers, okay, slightly dubious journal, I'm now thinking. They do the same study, open label, and they go, here's T3, how do you feel? And obviously, when they go on T3, their fatigue is less, okay? But this is the kind of thing we must stop doing because it's not blind, because it's completely misleading. So to conclude, really, non-blind studies are misleading, but they're still having an impact because people read these things and then they end up being referred to by various thyroid websites. Okay, so there's my summary. There's no evidence of T3 over T4. There's a very profound and prolonged placebo effect. This means that vulnerable patients are being taken advantage of, and trials of therapy need to come out of the literature because that's very misleading. Okay, thank you. Any thoughts? Questions? Is my thing working here?
That's really clear.